Okay, so if you're ready, I will go with a little presentation of the workshop and then we can start. So good morning, everyone. Today we will start this workshop entitled Modeling Parkinson's Disease Gaps and Facts. The speakers are Dr. Aise Ulusoy and Professor Donato Di Monte from the German Center for Neurodegenerative Diseases in Bonn, Germany. And today the topic will be moving forward with Parkinson's disease research. I will give you just a brief overview of the speaker CV. I will start with Aisha because please Dino for this, but ladies first. So Dr. Aisha Ulusoy graduated in Mptp University in Ankara, Turkey, and then she was recruited as a Marie Curie Research Fellow at Lund University at the Faculty of Medicine, and there she could work in collaboration with Denise Kirik and Anders Björklund, and was also tutored by Piers Emson. Dr. Aise Ulusoy, I would say, is a very young and talented scientist. She has been developing a lot of expertise in the field of Parkinson's disease modeling. And Professor Donato Di Monte is a senior group leader now, but also deputy scientific director at the German Center of Neurodegenerative Diseases in Bonn. He has been working in the field of Parkinson's disease since many years. And knows very well all the problematics related to the modeling of this disorder, because, for instance, he has been working with primates, different kind of models. He spent several years in the US, first as a postdoc at the University of California, Berkeley, and then he became group leader, lecturer, professor, and director of the fundamental research at the Parkinson Institute. And then he decided to come back to Europe, and he went to the German Center of Neurodegenerative Diseases. So I think it's the time to start the workshop. I know that the speakers are fully organized with the presentation, so I think Dino will start and then Isaac will follow. I would like to ask to the people which are connected if they can wait till the end of the workshop to do questions, or maybe they will organize. I don't know whether there will be the time. You will tell us whether you can have questions during the speaking. Okay, thank you very much.
Thank you. Let me see if I can share the screen. Okay, can you see the screen?
Yes.
Excellent. Okay. Okay, so now I can also. Thank you very much, Arianna, and thank you for all the participants in this symposium, and thank you for your nice introduction. I just noticed, Arianna, that you didn't, when you were describing my CV, you didn't call me young and talented, and I'm very envious because you do that. You did that with Aisha. Anyway, yes, I will give you just a brief introduction of what we're planning to do today and on Friday. So, modeling Parkinson's disease Of course, I don't need to emphasize why it is important, because it is only by modeling a disease or modeling aspects of the disease, important aspects of the disease, that we are able to ultimately understand pathogenetic processes involved in the development of these diseases, and of course, perhaps even more importantly, ultimately developing a strategy to counteract this process and ultimately to obtain neuroprotection or to prevent the disease and the disease development. So, but there is also an interesting aspect with modeling a disease, and this is true in particular for Parkinson's disease, because Parkinson's disease is a disease that has been changing. Our knowledge of the disease has changed rather significantly over the past decades. And so when we talk about models, of course, depending on our understanding of the disease, of our knowledge of the disease, the models have also changed with our concept of the disease. So that's the reason why what we have organized is important historical perspective of important milestones.
Please, the microphone.
Okay. So giving an historical perspective of what I consider some of the key milestones in terms of discoveries that have helped us understanding the disease. And then, of course, match that with the models. And today, in particular, we'll see also how far we go today, but we will focus on the pre-alpha-synuclein milestones and pre-alpha-synuclein models. And then on Friday, we will start with describing why alpha-synuclein, what alpha-synuclein discovery has done in terms of changing our understanding of Parkinson's disease, and as a consequence also changing our approach in modeling the alpha PD pathology. And then on Friday, we will also give you some example of how models that we have developed in our laboratory, or they've also been developed in our laboratories, could be used to understanding or to unravel mechanisms that might underlie the development of alpha-synuclein pathology. So let me start with a general historical perspective about Parkinson's disease. And this is again what we will focus on today. These are some of the milestones that I would like to briefly discuss with you. As you can see, then I've indicated with a dotted line the link between the milestone that I will describe that happened in 1983 and then what happened in 1997, which is the discovery of alpha-synuclein. But that is something that we will again discuss in greater detail on Friday. So let me start then. Of course, we all know that Parkinson's disease was first described by James Parkinson in 1817. But I think looking at different important events and milestones that have characterized the history of this disease, in 1912, Frederick Louis made an important observation and discovery. When I can, I will also give you some background about some of these very interesting people who have contributed to bringing the disease where it is. I mean, you might be confused, and when you go to meeting, some people talk about Lewy bodies, or some people call about Levy bodies. And of course, here in Germany, most people refer to Louis as Lewy. The reality is that everybody is somehow is correct. Frederick Louis was a very talented neurology in Germany at the beginning of the first decades of the 20th century. But, and in fact, his name was Fritz Heinrich Levi. What happened in 1933, I believe, when unfortunately the Nazi Party came to power in Germany, he was, since he was Jewish originally, he was thrown out of the university, which was basically Berlin at the time, the Charité in Berlin, and he emigrated to the United States. In the United States, I think in the middle 30s, 34, 35, he actually changed his name from Fritz Heinrich Levi to Frederick Henry Louis. And of course, in 1940, he also became an American citizen. So that somehow tells you just a bit about the story of these of these very talented neurologists who actually was trained and worked with Alzheimer's and other important figures in the field of neurodegenerative diseases. But in 1912, he made this interesting observation, and he described, and you can see here on this panel, the drawing that he made in the paper in which he reported initially these results. He described these intraneuronal inclusions in the brain of patients with Parkinson's disease. And we will come back to these on Friday, because I will stop here, but just to give you a general other information, the drawing that you see here, these are actually Lewy bodies and Lewy neurites in the dorsal motor nucleus of the vagus nerves. It's not the substantia nigra. Here you see the classic staining that used to be done until few decades ago, 2-3 decades ago, using the hematoxylin eosin to stain Lewy bodies within neurons. This is probably this is actually most likely a neuron in the substantia nigra of a patient, and the reason for that is that I think these dark brown dots that you see here, they are neuromelanin. And this is an electron microscopic image of these Lewy bodies, and most of them are characterized by a dense core, and then from this dense core you see these filaments irradiating toward the peripheral part of the Lewy body. So we will come back to this Lewy body tomorrow, because I think they have been, of course, also very important in terms of our understanding of the disease after the discovery of alpha-synuclein. But in the meantime, now what I would like to do is also tell you just a bit more about what happened in 1960 or in the late 50s and 60s, which is basically the discovery of dopamine and levodopa. Levodopa, and I think this is something that I would like to emphasize just a bit. Of course, this discovery brought or led to the Nobel Prize that was assigned in the year 2000 to Arvid Carlsson, who was one of the primary person involved in this discovery. But the discovery of levodopa and dopamine is actually a very interesting story for many reasons, and I will also tell you in a little while why I think that's the case. Levodopa was initially isolated in 1913 by Marcus Guggenheim, who was working in Switzerland at the Hoffmann-La Roche Institute. So he identified levodopa from a plant, from the fava beans actually, and the Vicia fava. And interestingly enough, at the time, he didn't know what to do with it, because he thought it was an interesting compound, but it wasn't patented, of course. The only thing that he did, which at the time was rather common, was, well, I discovered this compound. Let's see what happens if I ingest a lot of levodopa myself. So he ingested levodopa, and right after that, he had some symptoms, including vomiting and so on. So he said, not only I don't know what to do with it, but it seems to be not particularly good for you. So he basically let it go. And he let it go for a few decades, and only a few decades later, Carlson came out with an interesting use of levodopa. Carlson was doing experiments, and this is actually very much in theme with the overall theme of models. He was doing experiment in rats that they were treated with reserpine. In the 50s, reserpine was a drug that was actually was the first drug, I believe, that was used against schizophrenia. However, when patients were taking reserpine, they also became Parkinson-like, i.e. they could move very properly, so there were lots of side effects for reserpine. So there was a lot of interest at the time in understanding where this side effect of reserpine came from, and therefore people were using animal models to sort this out. And so one of the things that Arvid Carlson did was he injected animals with reserpine, and in this case he did rats and he also did rabbits, and he saw what somehow corresponded to what people were seeing in patients. The animals they slowed down, they became catatonic, and at a certain point, he made a connection with the possibility that this effect of reserpine may be due to other neurotransmitter, such as noradrenaline and adrenaline. And he thought maybe levodopa, being a precursor of these neurotransmitter, would be helpful in reversing these catatonia in animal models of reserpine-induced side effects. In fact, he injected the animals with reserpine, and to his surprise, and I'm sure he was very happy to see that the animals, they immediately started moving again. They seem to be, the effect of reserpine seemed to be reversed by administration of levodopa. And then, of course, he went further and he made the connection between levodopa and dopamine, because he was using what at the time was a fancy equipment, which I think it was only a spectrophlorometer, and using this and using a tagged neurotransmitter, he postulated that maybe the problem was the effect of levodopa was on dopamine. And he also made the other connection and said, well, maybe since the behavior of these animals and what we see in patients resemble what we see in patients with Parkinson's disease, maybe levodopa could be used for Parkinson's disease, and dopamine could be an important neurotransmitter in Parkinson's disease. When he came out with these ideas, and this was actually a rather quickly evolving series of observation and hypothesis, another scientist, an Austrian scientist, Oleg Ornekiewicz, he decided to go and to check directly in the brain of patients with Parkinson's disease. And when he did that, in fact, he saw that one of the a characteristic of this brain was the depletion of dopamine in the brain. And this was, again, in the 60s. From there, of course, the next big jump was to bring this to the clinic. And there was an initial clinical trials that was done actually by Ornekiewicz with a neurologist, another Austrian neurologist, Walter Birkmeyer. But then the big turning point was a few years later, I think in 1968, when another neurologist in New York, George Kotsias, did a proper clinical trials, and they actually saw that levodopa was very effective in counteracting Parkinsonian symptoms in patients. This was published with big fanfare in the New England Journal and had a major impact, of course, on the treatment of patients. Because you might already know, levodopa continues to be, actually this is wrong, it's not D-dopa, but levodopa, it continues to be the major drug for the treatment of Parkinson's disease. So the reason why I spent so much time describing the story, besides the fact that I think it's an interesting story, is the fact that it really shows something that we often discuss and mention about research, how much we need to integrate research from different fields. And I think the story of levodopa is probably one of the nicest examples that I can see, where you have from you start from the biochemistry, from the basic chemistry and biochemistry, the identification of levodopa, to the experimental research using animal models, then to the neuropathology and the neurochemistry, what Onekevich did, and finally to the clinic. So it's a full spectrum of interacting field that contributed ultimately to bring to patients something that has been and continues to be a fantastic drug, symptomatic drug against Parkinson's disease. So at this point of the game, this is what we became clear, that Parkinson's disease was due to the death of neurons in this area of the brain called the substantia nigra. These neurons project their axons to the striatum, and they use dopamine as neurotransmitter. And therefore, when these neurons die in the substantia nigra, one of the main consequences is a depletion of dopamine and the inability of these of dopamine to do what it normally does in the striatum, which is controlling the movement, and ultimately the absence of dopamine leads to the symptoms that we see, the motoric symptoms that we see in patients with Parkinson's disease. So then this is obviously another interesting aspect of it, but this is a good example of how from basic research you get to pharmacology and you get to therapy. So administration of levodopa would lead to levodopa gaining access to the brain and ultimately being converted from levodopa to dopamine in the brain and reversing the symptoms of patients with Parkinson's disease. But this is already a little problem, and the problem is that levodopa doesn't have an easy access to the brain. So once again, just a bit of smart pharmacology. What it was done already a few years after levodopa was found to be effective in counteracting Parkinson's disease symptoms. The administration of levodopa was combined with administration of an inhibitor of the main enzyme that converts levodopa to dopamine, carbidopa. Now, the interesting thing about carbidopa is that it doesn't cross the blood-brain barrier. So it blocks the conversion of levodopa to dopamine in the peripheral, in the periphery, in peripheral tissues, but it doesn't block this conversion within the brain. So as a consequence of that, much more levodopa gain access into the brain because, again, is not metabolized in peripheral tissues. And of course, the other major and important consequences of the association of levodopa and carbidopa is the fact that side effects that are due to the formation of dopamine in peripheral tissue, they're completely or they are significantly abolished by the co-administration of levodopa with carbidopa. So this is a very, very interesting, nice, and very positive story, which again, it's very important because levodopa and carbidopa continue to be, or levodopa and inhibitor of the AADC continue to be the main treatment for symptoms of motoric symptoms of patients with Parkinson's disease. But of course, the problem, unfortunately, is that when after years of treatment with levodopa and carbidopa, and as you can imagine, this is a slow progressive diseases that last years, so you have to treat patients for years. So when you do that, then you start seeing side effects of the administration of levodopa. And some of the side effects are in the form of what we call dyskinesias, which are involuntary movements. So the patients, it's almost like the opposite of imagining a patient with Parkinson's disease who cannot move. When these patients get dyskinesia, they move in a relatively uncontrolled way. There are also other side effects of long-term administration of levodopa, so that the wearing off effect, which basically sometimes the efficacy of the drug immediately stops, and the patients, they can go from functioning to non-functioning over a relatively short period of time. I will give you an example of this actually later on that might clarify all this. But the bottom line is that we have this fantastic symptomatic drug with levodopa, but it's not perfect, unfortunately. And that's why we have to continue to understand better and develop better drug, both from the symptomatic standpoint and, as importantly, from the point of view of treatment that can prevent and protect against the disease development. So the next thing I wanted to focus, which is also an important discovery in the early 80s, is the discovery of Mptp, once again connected to important experimental models, and Aisha will describe these in greater detail in a few minutes. But this discovery of Mptp is also a very, very interesting story, because I will try to summarize a relatively long and interesting story into a short story. What happened in the early 80s, these young individuals were admitted to the emergency room in a hospital actually near San Francisco, in San Jose in California. And so at the beginning, nobody really knew what, and in particular, there was one patient who was admitted, and nobody really knew exactly what was the problem with this person, because he was pretty much unable to move. So he was frozen, and initially people were even thinking of throwing diagnoses such as schizophrenic catatonia or things like that, but clearly this patient was not catatonic, because, for example, when you were trying to move his arm, there was really resistance, there was rigidity, very different than what you see with patients with catatonia. So it wasn't clear what was happening. And so after a few days of trying to understand what was happening, I think it was a medical student who said, well, maybe we can ask the patients, even if he cannot talk, maybe he might be able to write something and help us understanding what might be happening to him. And this is exactly what they did. You can see here the handwriting of the patient who was asked a very simple question, and although with difficulty, he was answering quick answers such as yes, no, yes, no. And I think I would like to point out, for example, on this little piece of paper that was saved from this initial conversation, he was asked, for example, if he had any medical conditions or if he took drug, and at that question he wrote heroin here. He was asked for how many days he had taken this drug, and he basically answered here 3 days. And then also he basically wrote Juanita Lopez, and Juanita Lopez was the girlfriend of this patient, and unfortunately, few days after he wrote this note, Juanita also was admitted at the hospital with a severe case of being frozen. So based on these interesting initial exchange of information, it was clear that probably this was a case of a problem started with the injection of illicit drugs. And after interesting, almost detective investigations, it turns out that this drug was synthesized in this garage, and by, of course, people who were trying to synthesize a meperidine analog. But unfortunately, in the process of synthesizing this meperidine analog, if you overheat some of the steps of the different steps for the synthesis, the chemical synthesis of these, you also generate as a side product this compound called Mptp. And Mptp turns out to be what is the culprit, what caused the Parkinsonism in these young individuals. By the way, I just want to tell you this because it's part of this issue of modeling gaps and facts and so on. But it's interesting, all this happened in 1983, but in 1978, there was another case this was a young student, a chemistry student in Bethesda in Maryland in the US, who also decided to synthesize his own drug. And so he thought he could do it. He was studying chemistry, so he went on and he tried to synthesize once again a meperidine analog. He probably did the same mistake in the synthesis, and he injected himself also with Mptp. The problem was that at the time, not only was very difficult, and this is again 5 years before all this story with Mptp then started in California, it wasn't very easy to find, to have a source of whatever this young person used to inject themselves. But interestingly enough, when they found this powder that was implicated in perhaps causing these symptoms in this patient, they tested the drugs in rats. And when they injected the drug in rats, the rats were okay. And this is an interesting observation because, in fact, if you inject Mptp, once we isolated the Mptp, once Mptp was isolated, we did all these experiments, and yes, if you inject Mptp to rats, rats are very resistant to Mptp. You inject it to mice, they are less resistant. In order to be able to see what Mptp does in humans, you have to inject Mptp to non-human primates. When you inject Mptp to non-human primates, to monkeys, then you actually see Parkinsonian behavior also in these animals. Raising an interesting consideration here in terms of saying, well, not only we need to choose our animal model knowing about the mechanisms of the pathology that we want to reproduce in the animal models and so on, but we also have to keep in mind, and most of all when it comes to diseases of the brain, our brain, the primate brain, is incredibly more sophisticated and potentially incredibly more sensitive to a certain kind of pathological process that the brain of other animals, such as rodents, for example. So this is something always to keep in mind. What I would like to do next is then to actually show you a vintage kind of video of the first patients again with the person I was talking about in terms of his experience in the emergency room, writing the initial notes about his diseases and so on. And this is just to show you the symptoms of these patients. This poor individual, he cannot move. You can see he's drooling, which is also something that we see in very severe cases of Parkinson's disease. So he really has severe Parkinsonism. You know, it looks like the tape is not moving, but actually is you can see is the patient that cannot move. You can see the slowness in movement, which is one of the characteristics of Parkinson's disease. So he cannot move. This is the rigidity, which is something else that we also see in patients with Parkinson's disease. Tremor, there is tremor that you can see that if you look at the tip of his hands. This is another test that we usually ask patients to do to see how quickly they can move their fingers and so on. You can see that it's very difficult for him. This is postural instability. You can see that the patient cannot really maintain posture. Now, the interesting thing is that if you give levodopa to Mptp injected patients, this is prior to the administration of levodopa, you can see the patient cannot move and so on, but you see immediately after giving levodopa how incredibly effective levodopa can be. This is the same patient. After levodopa administration, he can move, he almost looks normal. Actually goes back to all his old habits, including smoking cigarettes. But this is really perhaps a clearest example you can imagine of seeing how good levodopa it is in reversing Parkinsonian behavior caused by nigrostriatal degeneration, which is exactly what Mptp does in these patients. It kills neurons in the substantia nigra, it depletes dopamine in the striatum, so reproduces all the motor dysfunction that we see in patients with Parkinson's disease. So this is all good in terms of the response to levodopa, but guess what? Just like patients with Parkinson's disease, also these Mptp patients, they develop the levodopa complications to the levodopa treatment. This is another of the initial core of patients who were identified again in the early 80s. I would like you to pay attention to the time that is shown on on the screen. This is again an end of dose, a classic wearing off. Look at the time. This is 2 p.m. When the patient took the last doses of levodopa and carbidopa, so 2 p.m. And you can see that the patient can walk, can jump. This is 2 hours after the dose, so it's 4:22 p.m. So he took the dose at 2 p.m. This is 2 hours later, 2.5 hours, 4:22. So it still has, but see already 10 minutes later, 4:34, he is already slowing down. He is not anymore, as you can see, the movement are much slower. He's taking kind of a more posture typical of patients with Parkinson's disease. And now again, few more minutes later, you see how even more the situation deteriorated and how rapidly it deteriorates. So in a matter of 10-15 minutes, he went from normal. And then unfortunately, again, 4:49, few minutes later, the patient is pretty much frozen and confined on his bed. So this is once again a clear example of the wearing off effect of levodopa. And this is, again, another patient, another Mptp patient. These are classic dyskinetic movement. You see, he moves, he cannot control these movements. And so, as I mentioned before, this is why one of the reasons, perhaps one of the main reasons why we really need more and better treatment also from the symptomatic point for Parkinson's disease. So now what I would like to do, so I've shown you what was our thinking in terms of the 80s and 90s. So nigrostriatal degeneration, dopamine depletion, levodopa treatment, and then of course we also, the Mptp discovery in particular was a very interesting starting point for a lot of studies. And you will see that these studies have given us a lot of interesting clues. So one thing that, and I will give you 3 examples of important studies that that stemmed from the Mptp discovery and have given us very interesting information on disease relevant processes. So this is just a bit of a simplification of how we think and we thought at the time, but I still think that this is correct. How Mptp works. It is Mptp is not itself toxic, but need to be converted to his fully oxidized metabolite, which is called Mpp+. So this is a classic example of what they call in pharmacology metabolic activation. So you need to activate Mptp to make Mptp toxic. And when Mpp+ is formed, and this activation is most likely working through microglia in the brain, once Mpp+ reaches the extracellular space, it gets accumulated through the dopamine transporter into dopaminergic neurons. And in dopaminergic neurons, as well as in other cells, if it reaches the intracellular compartment of cells, he's accumulated into the mitochondria and it blocks mitochondrial complex 1. It's an inhibitor of mitochondrial complex 1, and this is one of the main reasons why Mpp+ and Mptp, they are toxic to cells. And of course, one of the main reasons why they're particularly toxic to dopaminergic cells in the brain is because of this active mechanism bringing in Mpp+ into the neurons. And then, of course, another important mechanism related that has been heavily studied is oxidative stress that might also be somehow dependent from the effect of Mpp+ on mitochondria and mitochondrial respiration. So one of the many things that happened at the time was, for example, that an interesting connection was made between Mptp and Mpp+. So everybody was interested on, of course, environmental agent, neurotoxicants. So there was everybody at the time thought, well, Parkinson's disease is probably due to toxic agent in the environment. So we are all looking at what they could be. And immediately attention was given to pesticides. And you can see that, for example, the chemical structure of Mpp+ is very similar to the chemical structure of a herbicide called Paraquat. And also Paraquat may resemble Mpp+ in terms of its mechanism of action that involve oxidative stress. And I think Aisha will tell you more about that in a little while. So Paraquat became an interesting potential environmental agent and the potential risk factor for Parkinson's disease. Another one is rotenone. Rotenone is a classic complex 1 inhibitor that we all use when we do experiment with mitochondria, for example. But rotenone is an insecticide. So once again, this is an example of in which they showed clearly how rotenone administration to rats, I believe, it depletes complex 1 activity, decreases complex 1 activity in mitochondria isolated from the liver of these animals. So rotenone is a complex 1 inhibitor, Mpp+ is a complex 1 inhibitor, so potentially rotenone might also be an environmental toxicant and a potential risk factor for Parkinson's disease. So as a consequence of these gave us interesting epidemiological clues, and these have been followed up for many years. This is just a study that was published already a few years ago, but this was an epidemiological studies in which they looked at risk for Parkinson's disease in individuals who have been using rotenone or Paraquat for their work, so pesticide applicators. And the conclusion of this study was that yes, being exposed to rotenone or being exposed to Paraquat, it really increases the risk by, in some cases, 2 to 3 times the risk for Parkinson's disease. So, and this is research that continue to go. So, you know, you say, well, is this stuff that was stopped with Mptp? No, it's not. In fact, I can tell you that there is a very interesting now, from the scientific standpoint now, we're moving toward the legal standpoint because there is a major, there are major court cases that are being currently brought to court in the US, most of all for Paraquat, and these are individuals who used Paraquat as a herbicide, and then they developed Parkinson's disease later on during their life, and now they're basically saying the company that was producing Paraquat, you are responsible for not for my disease. So this is something that again is currently ongoing, and I think, well, you know, maybe we can skip these, but quickly, it's going to be interesting to see, because I'm sure that during the course of these cases in court, there will be scientists that will be saying, oh yeah, Paraquat is bad, Paraquat is good, and this is simplified in this cartoon. You know, the scientific community is divided. Some say it's good, something is bad. On the other hand, you know, I'm sure that also the pharmaceutical companies will be pushing and saying, no, Paraquat is fantastic. I took this from the internet a few years ago, and you can see that the company that was producing Paraquat at the time was advertising Paraquat as, you know, nature working in perfect harmony. So it's going to be interesting to see what happens with this. But again, all this was prompted from the discovery of Mptp, what we knew using models with Mptp, and also with the idea that maybe in the environment may be toxic and similar to Mptp that can cause Parkinsonism. So this is an example of one of the implications of the discovery of Mptp. This is another example, another peculiar observation, and this goes back to the Mptp patients. And this is one of these patients. This is the case history of this patient. He started taking drugs at the age of 22. He used Mptp over a week at age 29, and of course developed severe Parkinsonism, as I have shown before, which was responsive to Levodopa and other dopamine agonists, but he also developed dyskinesia and hallucination. And this patient, unfortunately, died at the age of 42. And I think he died of a heart attack. So after he died, we were pretty, you know, we obtained, he donated his brain, we obtained his brain, and this is, you can see that when we looked at his brain even microscopically, you can see that there was a significant loss of neurons in the substantia nigra. So typical of what you see in patients with Parkinson's disease. But there was something that was very, very interesting, because I remember that Alicia Forno, who is the pathologist who was analyzing this brain, he basically, she noticed that there was severe nerve cell loss in the substantia nigra, which you would expect from somebody who injected himself with Mptp. But then what she said in her report was there was clear evidence in the tissue, in the substantia nigra of these patients, clear evidence of microglia activation, clear evidence of active ongoing process of cell death. For example, she noticed extraneuronal melanin, which is interpreted by pathologists as active, an active disease process, active cell death. So we were rather surprising for an obvious reasons, because how in the world this patient who basically was exposed to Mptp at the age of 29 and he died at the age of 42, so about 13 years later, how is it that in the brain of this patient there was still evidence of maybe an ongoing neurodegenerative process? And I remember that at the time, one of our hypotheses was that once these when the cell death was triggered with Mptp, it initiated a process that somehow remained in place and continued over the years, and maybe a process that involved neuroinflammation. In other words, there was perhaps an inflammatory response of the tissue after exposure to Mptp and Mptp-induced cell death, and then this inflammatory response persisted over the year, and instead of being the solution of the problem, might become part of the problem. So this was already hypothesized, again, in 1999 when this paper was published. But as you know, neuroinflammation has continued to be, and it is even now, an important area of investigations, also in terms of pathogenesis of Parkinson's disease and development of therapeutic drugs. Then I would also finish giving you one more example of important of what happened with Mptp in terms of developments that could be relevant to other patients or to understanding idiopathic Parkinson's disease itself. And this is cell replacement therapy. So what happened in the, I think it was the late middle 90s, there was a lot of interest at the time in fetal cell transplantation in the brain. So cell replacement therapy in the brain. Most of all, there was a group in Lund in Sweden that was very active in fetal cell transplantation. And during an international conference, Lindvall, one of the neurologists who was very much into again these studies in patients, he met with Bill Langston, who was the person who discovered Mptp, and it became clear, and we discussed this also among ourselves, and it became clear that actually when it comes to cell transplantation, perhaps the Mptp patients were a good candidate for cell transplantation. Most, in part because even though I've shown you before that maybe the neurodegenerative processes might be still ongoing over time, even after the exposure to Mptp, but these patients they have Parkinsonism as a result of a major single hit after injecting themselves with Mptp, whereas patients with idiopathic Parkinson's disease, they have an ongoing pathological process. So if you really wanted to test the effectiveness of cell replacement therapy, it would have been probably preferable to test it in patients where most of the degenerative process was terminated as a result of a single exposure, a single hit, rather than in patients who had a continuous pathological process ongoing as individuals with idiopathic Parkinson's disease. So based on this rationale, I believe that ultimately 3 of the original Mptp patients underwent fetal transplantation. And what I'm showing here is the results that were reported, I believe in 1992, approximately 2 years after the transplantation procedure in 2 of these patients, patient number 1 and patient number 2. And you can see that you look at with me with the results in this abstract. It says both patients had substantial improvement of motor function as a result of the transplantation, the fetal transplantation that persisted over the 2-year period that they were observed during. And also, very interestingly, there was also, this is an imaging technique, which is fluorodopa in the brain of these patients. You can see that prior to the fetal transplantation, there was very little uptake of fluorodopa, indicating really severe damage to the nigrostriatal system. 1 year after that, there was a significant improvement as a result of transplantation in the brain of these patients. So the bottom line is that, and I think later on, there was also additional follow-up with these patients, but 2 of the 3 Mptp patients who underwent fetal mesencephalic grafting, they did extremely well. The third one, she improved, but not to the extent that the other 2 did. And in fact, I think that the patient that you actually see, the first patient that showed up in the emergency room, the patient that I showed you in one of my videos, he died about 10 years after doing the fetal transplantation, and he did pretty well throughout those 10 years. So how is this relevant? Well, of course, it's a long story. I don't want to get too much into the issue of fetal transplantation in PD, which has had a strange and a very complicated twists over the past decades. But I just wanted to show you that this is coming back. In fact, Roger Barker, who is a clinician, I believe, in Oxford or in the UK, together with other people in Europe, they are now restarting a reevaluation of cell-based dopamine replacement, and they are proposing now to start another clinical trials evaluating the effect of transplantation once again in patients with Parkinson's disease. So again, going back to what we perhaps some of the clues that we have obtained out of the Mptp story that I've described to you. So I will stop here. I will actually give you just one more slide showing that and kind of transitioning to what Aisha is going to tell you more about some of these models. But the Mptp model has been extremely important from the translational standpoint. These are just some of the examples of translational research that has been done using the Mptp model. It has allowed us to develop MAO inhibitors against Parkinson's disease. It has really significantly helped the Mptp model to develop subthalamic stimulation as one of the treatment for patients with Parkinson's disease, and so on. So this really tells you how important it is to develop this model, to use properly these models, and even if we know now that this is not a perfect model, and we will discuss this in greater detail on Friday, but regardless of all this has been tremendously important from the point of view of also translational research and understanding pathogenetic processes that might underline PD, as well as developing new therapeutics. So I will stop here, and I will leave you to Aisha. But maybe what we can do, if you have some urgent questions, we'll give you maybe a couple of minutes for a couple of questions. Otherwise, Aisha will make her presentation. We will have more time to discuss or to address questions at the end of her presentation.
Thank you very much, Dino.
Thank you.
I don't know whether there are questions. I think it was a wonderful overview of the history of the modeling Parkinson's disease and of the Mptp model in particular, and how it has helped in addressing also novel therapeutic approaches. So, and it's really important to understand that we have learned a lot also from the old models. I think that most of them have been more informative maybe than the new ones from what we have now.
Yep, absolutely. I fully agree. And as I said, the most important thing is that the more we develop new models, the more we understand the disease and develop new models, I think we have to add to our armamentarium rather than substitute. And I think depending on the experimental question you have in the lab, some of these older models, and we can discuss these maybe later on, may be more valuable than some of the new models. So if you're interested in nigrostriatal degeneration, for example, some of these older models can still be extremely helpful in figuring out a process that they can be neuroprotective for these neurons.
Absolutely. Okay, thank you. If there are questions, otherwise we move on. Okay.
Okay, then I will share my screen. Do you see my screen?
Yes.
Mm-hmm. So, okay, so I will continue to a little bit more technical parts in regards to what Dino has presented today. And I will talk about the models that has been used until the discovery of alpha-synuclein, and discuss about these neurotoxin models that reproduce nigrostriatal pathway degeneration in terms of cell death, dopaminergic loss, and motor behavioral deficits. So just perhaps one important thing is that these models are developed for reproducing nigrostriatal degeneration, but later on we also noticed that their effects, some of their effects are not only nigrostriatal dependent. But today I will focus on their effects on the nigrostriatal pathway and their effects on dopaminergic cell loss. And on Friday, perhaps we can continue with their effects on non-motor symptoms or pathology outside nigrostriatum. So as Dino mentioned, the typical toxin models that are used in Parkinson's disease are 6-hydroxydopamine, Mptp, rotenone, and Paraquat. So just as a brief recap, what he has told, that they have contributed significantly to the translation of pharmacological treatments and also deep brain stimulation into practice. So the way that the reserpine treated rats and rabbits were used to develop L-Dopa. Similarly, rodent neurotoxin models have been very useful in developing dopamine receptor agonists that are currently used in Parkinson's disease treatment. And typically here, the 6-hydroxydopamine model was a more typical model that were used. And also the work that has been done with Mptp treated non-human primates has pioneered the application of deep brain stimulation in Parkinson's disease treatments. So these are historical studies that basically defined the functional connectivity of the basal ganglia and how it works. And these are the initial studies that helped developing deep brain stimulation for Parkinson's disease treatment. Apart from all these direct translational work that lead to therapeutic applications, of course, one should also recognize their applications in elucidating pathogenic mechanisms of neurodegeneration, Parkinson's disease, and dopaminergic cell loss, such as they help understand us perhaps why dopaminergic neurons are vulnerable to certain environmental stress, oxidative stress, mitochondrial dysfunction, as well as inflammation and perhaps also the impairment of protein degradation pathways. So I will first start introducing the 6-hydroxydopamine model because it's since Dino started with a historical overview, I also wanted to follow more historical order of events. So 6-hydroxydopamine is a dopamine analog, and it has been used since over 50 years as a Parkinson's disease animal model. So I will give more examples about how this model is used to assess nigrostriatal degeneration, as well as some behavioral models, and focus more on this model. But this doesn't mean that the other models are not as important, and because similar outcomes are also observed in other models. I will first introduce in more detail 6-hydroxydopamine and then go through other common toxin models of Parkinson's disease. So what makes 6-hydroxydopamine selective to nigrostriatal system is that because it's a dopamine analog, it is taken up by dopamine transporter into the catecholaminergic neurons, and 6-hydroxydopamine auto-oxidizes and generates reactive oxygen species, which we all know that are deleterious in the cell, that can damage the mitochondria, damage nuclear DNA, and impair autophagy, and eventually lead to neuronal cell death. So because it is taken specifically by the dopaminergic neurons. When we inject 6-hydroxydopamine into the brain, it will affect only the catecholaminergic neurons. Unlike MPTP, it cannot pass the blood-brain barrier, so we need to inject 6-hydroxydopamine in. So just as an overview, this is a rat brain, and so the brown staining is tyrosine hydroxylase that marks the dopaminergic neurons, and here you can see the substantia nigra neurons projecting to the striatum and making their terminals with the and connections to the postsynaptic neurons, which carry the dopamine receptors, and they project all together in a bundle called medial forebrain bundle. So when we inject 6-hydroxydopamine, typically they are injected only one side of the brain to cause a unilateral lesion. So pathologically, one can compare the injected site with the non-injected site in the same animal, which is one of the advantages, and one can develop specific behavioral. And depending on where we inject 6-hydroxydopamine, so if we inject it into the medial forebrain bundle, it affects all the fibers passing from the nigra to the striatum, leading to a complete lesion. Whereas one injects into the striatum, depending on how many sites that are injected, so how many deposits are being made and how much of the striatum is covered with the injections, one can generate either partial or severe lesions. And another paradigm is Nigral injections, which these also have very slight differences in the time of their action. So if we inject 6-hydroxydopamine into the substantia nigra or medial forebrain bundle, the lesion is complete within a week or so. Whereas in the striatum, the degeneration starts from the terminals and slowly progresses to the substantia nigra, giving a therapeutic window of perhaps 1 to 2 weeks. So the reason why I'm telling you this is that these are very, very acute models. So the neurodegeneration occurs in a couple of days to weeks. But one very typical thing with this 6-hydroxydopamine model that also helped us develop behavioral tests is the unilateral lesion paradigm that is used for these experiments. This unilateral injection of 6-hydroxydopamine leads to an asymmetrical motor output from the basal ganglia and causes a side bias that can be measured with specific behavioral tests. I will show you in the next couple of slides the drug-induced rotation tests and the cylinder test. I will not show a stepping test or skill pod test, also known as staircase, but the photo from on the right side is the staircase test, where an animal is placed in a box with sugar pellets that the animal can reach the sugar pellets only with one hand because there's a barrier between the two in the middle, and one can very nicely measure how many pellets an animal can grab, pick up, and reach to the mouth to give a very nice, accurate measurement of the use of the paw. So this is drug-induced rotation tests. The reason why it's called drug-induced rotation is because a drug is injected. We typically use either amphetamine or apomorphine, and depending on how the drug acts on the brain, so amphetamine is a dopamine-releasing agent. It causes release of dopamine, and in a unilateral lesion animal, because the lesion site does not have much dopamine left, most of the dopamine will be released from the contralateral side, causing the animal to rotate ipsilaterally towards the lesion site. Whereas apomorphine acts on the postsynaptic receptors, on the dopamine receptors in the striatum. And you might think that, oh yeah, so these receptors might not be that active anymore. It's actually on the contrary, because of the lack of dopamine on the injected side, the receptors have a compensatory effect and becomes hyperactive. So these to be able to detect even small amounts of dopamine and react to small amounts of dopamine. So when we inject the animals with apomorphine, what happens is that the animals will have more stimulation on the lesion side this time. So, and these animals will then rotate contralaterally to the lesion side. Just as a quick example, this is an experiment that we have done in our lab, animals with striatal lesions, with partial lesions to site injection into the striatum, or MFB lesions to the medial forebrain bundle, which has, you can see that amphetamine injected animals with full lesions rotate very much more compared to the striatal lesioned animals. And that is also different than the control animals. Whereas apomorphine, in that case, they go minus in terms of their ipsilateral turn, and it causes a similar effect. So partial lesion could be measured and can be compared with fully lesion. This is another test called the cylinder test. And in the cylinder test, we place the animals in a glass cylinder. A normal rat, they are very nice, very curious animals, will start using both their hands to explore the cylinder, use right and left, more or less the same number of, same number of touches. This is a full lesioned animal. You can see that it is very slow, shows some bradykinesia, and only uses one side. So they don't use, so these are injected to the right side of the brain, so they cannot use their left side as much as their right. And here you can see that one can measure the number of paw touches and differentiate between the different different severity of the lesions. This is something that, of course, another outcome of nigrostriatal lesions, that there will be decreased dopamine in the striatum, which can be measured by dopamine measurements. And here, this is an example of animals with partial or full lesions that could be this decreased dopamine, which is shown with the red bars, could be recovered by L-Dopa treatment, Levodopa treatment in partial animals completely. In complete lesion model, the animals did not have a lot of dopamine terminals left. They cannot generate a lot of dopamine, but still you can see some recovery. And in terms of pathology, in the substantia nigra, these animals, depending on the dose, they have very severe or partial lesions. You can also see it on the injected side, in the lesion side striatum. The terminals, the brown staining is tyrosine hydroxylase, and you can see that when the dose is high, there is almost nothing left in the striatum as compared to the intact side. So this is the same animal and the intact side of the brain. Whereas in lower doses, you can still see some dopamine terminals left in the lesion side. This could also be quantified either by serologically counting the tyrosine hydroxylase positive cells in the substantia nigra, or by doing density measurements in the striatum, which is not shown here. So just as to mention the other features of 6-hydroxydopamine model, as Dino mentioned, there is, when we treat patients with levodopa, most of the patients will eventually develop L-Dopa-induced dyskinesias. This is an example of a patient with dyskinesia. You can see that has difficulties controlling their limb movements. Some also postural disabilities, axial dyskinetic movements. So it's not one-to-one comparison as in the patient, but when we treat fully lesioned animals with L-Dopa over time, these rats also develop eventually L-Dopa-induced dyskinesias. Here, one can quantify or score the axial dyskinesia, which you can see that the animals rotate towards the lesion side. They cannot control that movement. And also they have limb dyskinesias that they cannot control, and that's why the poor animals trying to hold the limb. Also, I don't know if you can notice, there is also some small amount of orolingual dyskinesia that one can also see that the tongue rotates, and it also causes involuntary movements. Oops. Okay. So so Dino did mention about the Mptp patients being treated with cell therapies. Cell replacement therapies have been thought as a therapeutic or experimental therapeutic strategy because I think it's not very realistic to assume that fetal cell could be generated for every Parkinson's disease patients, but nowadays the field is moving towards using pluripotent cells from humans and transplanting them into the brain. And most of these studies are performed in 6-hydroxydopamine model because the model allows us to deplete the dopamine on one side and completely see how much the transplant has integrated and what to what extent is functional. So these are functional studies in rats after transplantation of cells into the striatum, and you can see that with falipride, which is a dopamine binding PET ligand, and with I think that's the other one is fluorodopa. You can see that the dopamine receptor binding and that binding increases with transplantations. And one can already also assume that these could also be applied to patients, perhaps in the future. These are from patients that received fetal transplantation, but as Dino mentioned, that probably the field will move towards generating these transplants from other sources like the pluripotent stem cells. So let's move to the Mptp model. So the Mptp, after it was discovered discovered that it caused Parkinson's disease, Parkinsonism in humans, the researchers administered them into research animals. And what it does is, of course, depending on the species that is used. So, for example, Mptp is very ineffective in rats, but causes very similar symptoms like Parkinson's disease in non-human primates. It's also been very broadly used in mouse models. So here you can see this is a macaque rhesus monkey that was administered chronically with Mptp or subchronically. I think this is 1 week treatment of Mptp. And on the left-hand side, you can see that the monkey has a postural problem, the flex posture. They are very bradykinetic. Here it's actually akinesia. They are rigid and they cannot very well move. Whereas when the same animal was treated with L-Dopa, on the right-hand side, you can see that the animal goes back to its normal posture, is active, and is very well responded to L-Dopa. And one of the most important thing about the Mptp model is that it reproduces a very similar behavioral phenotype as compared to Parkinson's disease. And probably this is why that the Mptp treated monkeys were used broadly to understand the basal ganglia circuitry. Here in the table, you can see that there is a comparison of humans and non-human primates after Mptp-treated monkeys. that they both show akinesia, rigidity. The tremor is slightly different in monkeys, that they don't get resting tremors, but other than that, they have flex postures, they have eyelid closures, they drool as well, and they have decreased vocalization, which could be translated from as mutism in Parkinson's disease patients. And similarly to what I have described in the 6-hydroxydopamine, which I will not go that much into detail, but in Mptp model there is nigrostriatal neurodegeneration, and as well as loss of dopamine. And here, the reason why I wanted to show this this experiment is that in Mptp there is a slightly longer progression of the disease as compared to, for example, the 6-hydroxydopamine model. And tomorrow we will come back to this, that Mptp, because it is treated systemically, it affects other regions in the body, and also has other features than nigrostriatal neurodegeneration. But today let's stick to the nigrostriatal part of the model. It generates a very typical nigrostriatal neurodegeneration, which is then could be reversed by L-Dopa treatment. They also induce L-Dopa-induced dyskinesias over time. And in fact, one can also say that perhaps the L-Dopa-induced dyskinesias in Mptp-treated monkeys are perhaps a better comparison to what has happened in Parkinson's disease patients, because in L-Dopa, in 6-hydroxydopamine model, the depletion of dopamine is almost complete, and the animals develop dyskinesias after 4 or 5 daily L-Dopa treatments, whereas in Mptp it's more of a longer process, and therefore these models, these animals, have been used more commonly to work to develop medications against L-Dopa-induced dyskinesias. One of them is amantadine. There are many more that has been translated to clinics. That was developed in Parkinsonian Mptp-treated primates, and they are currently still in use for Parkinson's disease L-Dopa-induced dyskinesia treatment. So we can go back to the Mptp model perhaps tomorrow shortly again, but I also want to mention the other models that are commonly used in Parkinson's disease research that leads to nigrostriatal neurodegeneration when given systemically or injected locally. So rotenone is a very common drug that is used for mitochondrial activity research because it's an OXPHOS inhibitor. But more than that, it is a pesticide, it's an insecticide and a pesticide, and its exposure has been linked to higher risk of Parkinson's disease in humans. So on the right-hand side, you can see when in rodents, when animals receive rotenone systemically, they develop striatal terminal degeneration. So this is bilateral, of course, because it's given systemically. And in the substantia nigra, one can see cell loss, and neurodegeneration. Depending on the route of administration, it might cause different effects, but generally speaking, it has an effect on dopaminergic system, and specifically to the nigral dopaminergic system. So there is some sort of selective vulnerability of these neurons against rotenone. And tomorrow we will also talk again about its oral treatment that is also used today as one of the models of Parkinson's disease outside nigrostriatal system. Another model that is also commonly used in Parkinson's disease research, and it's also a model that we use in our lab, is Paraquat. It's a herbicide that was used worldwide, and I think it was 2007 that was banned in EU, but it is still being used in some countries in Latin America and perhaps in Asia. Unlike the rotenone and Mptp, which acts directly on the mitochondria, Paraquat causes oxidative damage through redox cycling. What happens is that this reduction is catalyzed by enzymes such as the NADPH oxidase or NOS, and this reaction causes the formation of superoxide radicals. So this is one of the mechanisms of Paraquat action that Dino's former experiments has shown, that perhaps the way that Paraquat works is that an initial priming with Paraquat or another toxin will induce microglial activation, and a second injection of Paraquat will then lead to the oxidation of Paraquat in the microglial cells through the microglial NADPH oxidase, and lead to oxidative damage, leading to neuronal cell death. And this systemic treatments, I actually find it very interesting that these systemic toxins go and lead to cell death in the substantia nigra. And this is perhaps another topic for maybe later on, not during this course, but maybe next year. Is that they lead to cell death specifically in the substantia nigra, because nigral neurons are more vulnerable to these toxins, to oxidative stress, to mitochondrial impairment. And here you can see that there is a dose-dependent loss of tyrosine hydroxylase positive neurons in the substantia nigra after Paraquat treatment. Twice Paraquat treatment, like the one that was shown in the previous slide, that requires perhaps a priming. And also this effect can be age dependent. You can see on the bottom right that animals that were injected when they're 18 months old show more cell death in the substantia nigra as compared to animals that were injected earlier in their lifespan. So I come to the end of this introductory talk to toxin models. And as a conclusion, what we can say that is that the neurotoxin models have been very useful and valuable. And today we also use them extensively to understand the pathology, understand the mechanisms underlying dopaminergic cell loss. Here I presented you the nigrostriatal aspect of the toxins, but tomorrow we'll talk more about what they do in other brain regions, or not only in terms of nigral neurodegeneration, but also perhaps pathology. So their representation of the disease is unfortunately partial, because we know that, or tomorrow Dino will mention that Parkinson's disease is not the nigrostriatal degeneration only, and it affects the entire body. Most of the time these models are very acute, and therefore it does not recapitulate the progressive aspect of Parkinson's disease. And technically this also makes it very hard to find a therapeutic a window of time that we can recover perhaps neurodegenerative changes. So it's very hard to work with, for example, 6-hydroxydopamine model in terms of finding neuroprotective therapies. So perhaps if one needs to discuss of improving these models, is perhaps to make them slower and generate a more longer therapeutic, longer window for therapeutic applications. Their predictive value has been questioned several times, so not for the dopamine replacement therapies or the fetal cell transplantations, but to develop neuroprotective strategies, which probably it's because Parkinson's disease is not only nigrostriatal, is not a nigrostriatal neurodegeneration, but contains other pathologies, and perhaps the disease is not only confined to the nigrostriatal system. So yeah, this is all from my side today. If there are any questions, we can take the questions. I also put a link here that if anyone wants to write their thoughts, if they have any suggestions, if they have any thoughts about what they think that these models could be useful or their limitations, please leave in this link. There will be cards that you can add in, and tomorrow we can have a quick look in these links.
Thank you very much, Aisha, for the clear description of the different toxin models, highlighting also the differences between them. And if there are questions, I think we can address some of them also directly. Maybe the young student.
May I maybe ask something? Is so the group of people here that are listening, are they all doing Parkinson's disease research or neurodegenerative diseases? Anyone using toxin models in this group?
I think some of them have been using a toxin model because here in Brescia, I mean, there is an history on the study of Parkinson's disease, especially with the 6-hydroxydopamine. At the moment, for instance, we have a collaboration with another group in Cagliari, and they are using the Mptp probenecid chronic model, and we are addressing some issue concerning the synaptic function and alpha-synuclein accumulation as well, because in the chronic Mptp you also have the synuclein pathology. There is a question.
No, I think one. Oh, yeah. There is one comment on the chat, but yeah, thank you. Van Cliffa has left a note.
Nobody wants his question at the moment. The young people, I don't know.
Maybe we can just one general consideration that perhaps can be made, and I think it's something that will become even more clear after the next presentations on Friday. I just wanted to not to scare people. Aisha kept saying tomorrow. No, it's not tomorrow, it's on Friday.
Oh, no, sorry, yes.
So anyway, but I think I've already mentioned the fact that sometimes we swing to the new things, to the new model, to the new aspect of the disease. I think it's going to me, the most important thing is that compared also with other neurodegenerative diseases, if you, for example, you make a comparison with Alzheimer's disease, we in Parkinson's disease somehow, one little thing that is to our favor is that we do have a lot of these models that reproduce different and specific aspects of the disease. You know, to give you an example, some of the toxin models that Aisha has described today, and they are related to studies and discoveries that have been made now 30 or 40 years ago. The reality is that it remains, again, always a key question to match the model to the experimental question. To give you a simple idea, to me, one of the most fascinating, intriguing, probably one of those things that is going to be almost, I feel like impossible to solve, is the issue of dyskinesias. Dyskinesias are really, really an interesting pharmacologic puzzle. And if you think about it from the point of view of therapeutics, if we could prevent dyskinesia somehow and maintain the efficacy of levodopa, it will have such a tremendous beneficial, immediate beneficial impact on the patient. So it is surprising that there isn't so much research being dedicated and focused on dyskinesia. Now, perhaps it's relatively less surprising considering the fact that it's a really, really tough area of research. I touched on these for many years throughout my career. Aisha's done the same, Ariana, but it is really difficult. Going back to the models, if somebody would say, okay, do we have models for dyskinesia? Yes, we do. And these are these old-fashioned models with the Mptp, with this hydroxydopamine. Nobody would dream to use an alpha-synuclein model, for example, to study dyskinesias. So once again, I think the critical message here is to, again, take a broad perspective to a disease such as Parkinson's disease, have a clear idea of how the disease has developed throughout the years, these critical pathophysiological features of the disease that have been discovered over the years and sometimes decades, and then ask specific questions. If the question is, can we, for example, protect against nigrostriatal degeneration specifically, maybe some of these models that are more specifically focused on nigrostriatal degeneration may be more directly pertinent than other models that might reproduce other kind of pathology. So once again, I think for young students or for young investigators in the field of Parkinson's disease, I think the good news is that we do have models. The bad news is that there are always better models, and I think we should continue to develop our models. But fundamentally, I think the models are as good as our knowledge of the disease is. The limitation of some of these models, such as the Mptp model, and was not that the models was bad. Absolutely, the limitation was us. We did not know about the existence of alpha-synuclein when we were using these models. So how in the world would we even dream of reproducing alpha-synuclein pathology at that time? So the model matches the knowledge about the disease, matches specific aspects of the disease that at the time we were focused on, in this case nigrostriatal degeneration, and they don't become obsolete just immediately because a new model has come in place, because they maintain the validity to address specific experimental questions. So that, I think, is the most important. We need to know the model, we need to know the limitations of the models, such as what Aisha was mentioning before. Yes, I think a major limitation of some of these toxin models is their acute paradigm. So for a disease such as Parkinson's disease, that's most likely developed in humans over decades, it's very difficult to imagine that something that kills neurons in a matter of days or weeks may ultimately reproduce the disease. On the other hand, it is also true, the opposite argument you can make, that if somebody would find a perfect drug that would protect against 6-hydroxydopamine, good Lord, it will be a hell of a good drug to try in Parkinson's disease, because some of these agents, they are rather dramatic in terms of their effect. I mean, to the best of my knowledge, and believe me, we've been working with the Mptp model now for many, many decades. A lot of times when I see people publishing work on neuroprotection against Mptp, usually you have to be very careful in digesting that information, because to neuroprotect against Mptp is very, very, very difficult. The most effective drug that I've ever used to protect against Mptp is a monoamine oxidase inhibitor. Why? Because they prevent the bioactivation of Mptp to MPP+. And believe me, it's incredibly effective to the extent to which, and this is something that might be interesting also for you to know, if you work with Mptp, and of course you have to have safety precautions in your laboratory, but please keep in your drawer a monoamine oxidase inhibitor, because if you, for example, and it's unlikely, and it's not, but if you get exposed to Mptp, let's say that you even in a moment of desperation because whatever happened in your life, you decide to inject yourself with Mptp, don't do that. But if that happens, the next moment, take your monoamine oxidase inhibitor, you will not have Parkinson's disease. So these things work, and they work very, very effectively. Another way to protect against Mptp is using, for example, inhibitors of the dopamine uptake, because then you prevent the access of MPP plus into the neuron. So these things work. Other mechanism of action of Mptp or other protective effect of Mptp that have been described, they may or may not be as easy to use and applicable in terms of therapeutics. But still, again, the models is extremely efficacious. And I think most of all, taking into consideration the fact also what Arianna was mentioning, that one of the most interesting things that we will discover, and again, we will maybe discuss in greater detail on Friday, is that these toxic models, they do have an effect on alpha-synuclein as well. So it's interesting to see how somehow ultimately research that was developed prior to alpha-synuclein discovery ultimately can be complemented by the discovery of alpha-synuclein years later. And I think perhaps understanding how these models may ultimately, or how these pathological pathway, the alpha-synuclein pathology that again we will discuss in a couple of days, or the nigrostriatal pathology, how they interject to each other, I think it's going to be a very, to me, it's a very, very interesting and potentially important line of research.
I think it's an hot topic. I mean, match the oxidative stress and the mitochondrial dysfunction with alpha-synuclein. This is going to be.
Yep,
there was a question that
yes,
perhaps we can. So one of the students asked about the zebrafish model and Dyskinesias. I think one should also appreciate the presence of non-mammalian models of Parkinson's disease, and I think they are very useful for high throughput screening and looking into cellular mechanisms. However, I think although it is a valid output, their behavior in Drosophila or zebrafish, I wouldn't call what a zebrafish would develop as a response to L-Dopa dyskinesia. They might have freezing episodes, but I think it's an output of the experiment, and it's very welcome to use. But I think for when we talk about more basal ganglia, even rodent models sometimes have their limitations, and most of the time this is why the primate models become more valuable in terms of the basal ganglia circuitry.
Yes, absolutely. Mm-hmm. Although there is an interest for us because we have a very developed, a very good zebrafish facility. So,
well, you can do with zebrafish things that will never be done with monkeys, of course. I mean, there are things that some of these models they definitely have a niche in terms of filling up a gap that you cannot fill up with rodents or with monkeys or with So I think once again the issue here is not is to choose the right model, and I think the question that was raised is an interesting one. If I would develop an interest in Dyskinesias, well, maybe zebrafish wouldn't be my first priority in terms of a model to use. On the other hand, if I would, for example, I don't know, develop an interest in testing genetic, maybe some of these models, even C. elegans become a fantastic model for PD. So once again, please match the model to the experimental questions, and once again take advantage of the fact that we do have a variety of model, and that's to me is something that it's critical as a result of all these discussions that we have. Unfortunately, we all have our pets in terms of models that we like more, we like less, and sometimes we like to stretch our model maybe to address questions that might not be best addressed with that model. But most of the time, again, it is to our own advantage to choose the best possible model, because you increase your probability of getting results that ultimately will translate into good science and possibly moving forward with the research.
And I think tomorrow's, the Friday's conversation is gonna, yeah, sorry. So Friday's conversation will also, summarize this in a better way. But I think what's also important to know is that, animals do not develop Parkinson's disease. And when it comes to using the right model, perhaps one should also think of specific targets of the approach. What do we want to target? Because I think, at least until now, there is no real Parkinson's disease that one can develop in. So if we're talking about Parkinson's disease symptoms, yes, Mptp or 6-hydroxydopamine, or I think Mptp model will reproduce very well the Parkinson's disease symptoms. But Parkinson's disease is a very complex disease, and we don't have right now the model. So in terms of experimental questions, I think one needs to complement what Dino has been saying, one needs to choose the right species, the right target, the right model for answering the specific experimental question in hand.
Yes. For instance, in the zebrafish, there is no endogenous alpha-synuclein expression. That's an interesting point.
Yeah, but it could be interesting, because perhaps it could be twisted around, and you can say, okay, maybe my question is to see what happens if you start expressing alpha-synuclein under conditions in which the neuron or the cells may normally not see alpha-synuclein.
Yes,
and I asked that question because it's an intriguing question, because alpha-synuclein we're moving toward alpha-synuclein more and more, which is good. It's in preparation for tomorrow, Aisha, for Friday. But I think that alpha-synuclein, and we can speculate even more on these, is a kind of a schizophrenic protein. It's there. We express a lot of it. We have a lot of it, but it also is potential toxic, which means that somehow the neurons need to keep that in mind when they deal with alpha-synuclein. As you probably know, but there is, for example, a lot of alpha-synuclein during brain development. Absolutely. And that alpha-synuclein during brain development is, the neurons can handle it very well. And the reason they can handle it very well, because during development, for example, it might not be the only reason, but during development there is a lot of chaperones molecules that also express in these neurons. So you have this protein that can be potentially toxic, but the neurons seem to know it, and they have a lot of chaperone to deal with it. Now, very different is the situation in adult brain, where alpha-synuclein is not, for example, in the cell bodies, you don't see alpha-synuclein. It's made and it goes to the terminal. So when you start seeing alpha-synuclein in the cell body, maybe the cells don't know anymore how to deal with it, which create, that's why, going back to your question or your consideration, Ariana, yes, it might be interesting to see what happens in a cell that is not prepared to deal with alpha-synuclein, to maybe reproduce something that might be a situation that might even happen in the human brain, in the cell bodies, for example. And that, as I say, once again, the interesting thing about research and science is that, yes, you can take also something that potentially is, say, well, they don't have alpha-synuclein. Well, that might be good in some instances, as long as your experimental question focuses on an aspect that can take advantage of the fact of not having alpha-synuclein.
Yes. Okay, so if there are no other questions, I think we can close here, and
thank you very much.
I'll see you on.
It was enjoyable. We will see you.
I thank you both very much because I think it was a very nice presentation, and we had. I think that with this last discussion, we also addressed some points which is really important to understand when you want to model or address some scientific question in the field of Parkinson's disease.
Absolutely. Okay, so we will see you again on Friday.
On Friday.
Thank you again.
Bye.
Thank you.
Sure.
Bye bye.